Hello, it's really very nice of you all to join us. I've got Johnathan Ramsay here with me, who I think we made a bit of a mess of our first session. I didn't press the right buttons. Alice, bury your head under the pillow. But here come some questions. Johnathan is one of the most foremost male fertility experts in the UK, and he knows everything there is to know about sperm, really. So I'm going to start with a couple of questions that come up a lot in my clinic and both in his. And the first one is about physical examination of the testicles. Now, men are not very pleased at the idea of having somebody rummaging around their testicles, whereas women have lots of examinations and things like that. So this particular question was from somebody whose partner has a high DNA fragmentation. I'm sure that will come up later in the conversation. And he's had, they've had 2 failed ICSIs, and he has not had a physical examination of his testicles. So, Johnathan, what do you think? Do you think a physical examination is really something that men must have in order to find out a bit more about what's going on?
Well, I do. And I suspect all of you would think, well, he's bound to say that, isn't he? Because that's what he does. But I genuinely believe that we can get lots of information from a physical examination. One immediately can appreciate the size of the testicles and have some idea, therefore, about whether fundamentally the man in front of us is normal, whether in fact he should be producing good volumes of good quality sperm. And if his DNA fragmentation isn't quite right, then we suspect that there may be a cause of extra heat in the scrotum, which is commonly caused by having a collection of veins around usually the left testicle, known as a varicocele, which actually warms the testicle up and creates less good sperm production, but in particular a reduction in the DNA quality of the sperm. So I think that physical examination is nearly always indicated. Sometimes, of course, men will have already had an ultrasound scan, but even so, to understand some of the subtler changes that can happen physically, a physical examination, I think, is important.
Good. And that just helps us move very easily into another question which we had, which is about varicocele. So this is somebody who has a very large varicocele. They have had a child through ICSI, but failed the last cycle. He will have surgery, but he has 0% count. And they want to know, really, Johnathan, will varicocele surgery make a difference to the sperm count?
Well, it may well. And this does move on from the last question, because this question is about, or states that it's a very large varicocele. Now, of course, the degree to which the varicocele heats is related to how big it is. And with an ultrasound scan, you can actually measure the diameter of the veins. And so we know how big that varicocele has to be before it may be causing a significant problem. Now, with azoospermia at the present time, we can assume that previously, when this gentleman and his partner had ICSI, that there were some sperm. So as often happens, there has been a deterioration since the previous ICSI. Now, as long as something else hasn't happened, he hasn't had another illness or some disturbance of his hormones, if the only thing that is evident now is this large varicocele, then it is quite likely that getting rid of it could restore some sperm to the ejaculate, thus to allow them to have another cycle of ICSI.
Fantastic, thank you. So another question that again comes up really a lot in my clinic is the effect of smoking. How does smoking affect sperm? And this is a 20 plus a day for quite a long time. What is the actual effect? We know that smoking is probably bad for sperm, but what is your opinion on this, Johnathan?
Okay, so undeniably smoking is bad for sperm because not only is it bad for health, but it is particularly bad for DNA and its replication. We know this because, of course, smoking is involved in nearly every kind of tumour, of cancer, because of its effect on DNA. And we can now, of course, measure the effect of smoking on the DNA in sperm by measuring the DNA fragmentation. And one sees pretty significant changes, that is, deteriorations in DNA fragmentation in habitual smokers, and almost always significant improvement in the DNA quality of the sperm after ceasing smoking, although this may take up to 3, 4, 5 or even 6 months.
Thank you. And actually, what do you think, since we're on the subject, what do you think about vaping?
So one has to discriminate the differences between the nicotine, which of course is why people smoke, and the tar in tobacco smoke, and the carrier chemicals in the vaping fluid, which of course is merely a vehicle for the nicotine. So these vaping fluids, as vapors, all vapors know, are very different. They're different temperatures and they have different constituents. Now at the moment there is weak evidence that people, in inverted commas, who vape may be less fertile, men who vape. But of course we haven't discriminated one set of chemical carriers from another, nor have we clearly discriminated the difference in the different temperatures of the vapour that is inhaled. But in broad terms, I think one can assume that any activity, any inhaled substance which might damage your lungs, as has happened in some vapours around the world recently, is likely to have a damaging effect on delicate metabolic processes and particularly sperm production.
I've heard that it's the flavours that actually are the worst. Butterscotch particularly, so take note, you butterscotch vapors, but probably best to kick the habit completely. And what effect do you think weight has? So we've had a few questions about overweight. Men have not been told to lose weight. Women are always told to lose weight in an IVF clinic, but men are not told to lose weight. So do you think that weight has a significant effect on, say, count or morphology?
Well, the straightforward answer is yes, I do. But there are lots of different components of just being overweight. Perhaps one of the most significant things, I think, is how you became overweight. So what was your nutrition? What was your diet? How did this happen? Because certainly if one looks at the decline in male fertility and plots it against other things that are happening to Western societies, then the line that charts increase in BMI, and particularly waist circumference, is in parallel to the declining line of male sperm counts. Now, it's too simplistic to say that the one is related to the other, but it is related to the multifactorial issues that cause us to be overweight. So there's the nature of the diet, the processed foods that are implicated, of course, in heart disease and colon cancer, but at the same time there is the distribution of the fat, because the fat that gets distributed around the waist that results in an increase in waist circumference is metabolically active fat and actually causes or helps to reduce testosterone levels naturally in nature. So the more of this waist-bound fat and visceral fat that a man has, the lower may be his testosterone levels, thus compounding the reasons that he got fat that may also be affecting his spermatogenesis.
Oh, good. Sorry, I've got my head turned so that I can see some of the questions. That's very interesting because that does come up a lot, and I always personally try and encourage people to lose weight, particularly around their middles, because that's a bit of a dangerous place to have fat. in terms of sperm, and certainly the research that I did looking at sort of inflammatory mediators that come out of abdominal fat that damage sperm. And of course you get very hot if you're carrying a lot of fat around the middle. It radiates a lot of heat.
I think that's a very good point, because of course the fat may be in what we call the suprapubic fat pad, and maybe in the upper thighs. And we were talking 2 questions ago about the heating effect of varicocele, and similarly a lot of extra weight in the groins and the upper thighs and the lower abdomen may have exactly the same heating effect.
Yes, people often ask about jogging, obviously, in fact, reminds me, I'm going to come on to cycling, because these are all questions that nobody really ever gets a particularly firm answer from IVF clinics or GPs, and nobody quite knows. But certainly with jogging, I remember a colleague of ours saying that if your legs were a bit chunky, so you're either a little bit overweight or a bit built like a rugby player, it's like rubbing 2 sticks together when you go for a run. It causes a lot of heat, which brings me on to cycling, the dreaded question of cycling. How much cycling, and in what circumstances would you say that a man should totally give up cycling, go on an exercise bike, or do their 70-kilometre rides in their lycra all stuffed up?
So I think it comes back to the question of the heat. And so it's about how long you do it, what you are wearing, whether you're drawing your testicles into your body with clothing that insulates, and of course whether you're actually sitting on a saddle which is pressing on your prostate. And so if we go back to the heat issue, I think men in particular like numbers, and I was touching earlier on the numbers that matter. So the scrotum and the testicles like to be 3 degrees below core, which is about 37 degrees, and of course as soon as we begin to feel hot, we are above core temperature. That's part of the body's natural cooling process. So if you feel hot, then it is too hot for your testicles. So it's all a matter, I think, of duration of the exercise, and preferably it shouldn't be the sort of cycling that many people do, indeed for relaxation. It's the 10 and 15 kilometres a day and 50 at weekends. A gentle commute, which is not a race down the embankment in a sort of peloton, a gentle commute in a sit-up and beg bike, absolutely fine. But as we move away from that into this heating experience for half an hour, 40 minutes an hour, I think it probably is physiologically deleterious. But I am mindful of the fact that it is a great relaxant. It's a releaser of endorphins and can be, like many other forms of exercise, peculiarly addictive. And so one, I think, has got to balance all our advice in such a way that it doesn't actually have a counterproductive effect, because it makes the man totally miserable.
Yeah, I completely agree, actually. I always say to my clients, men are like dogs and they've got to be exercised on a regular basis. And cutting down their exercise just makes them absolutely miserable. Well, actually, it makes women miserable if they exercise a lot too. But I think there's a particular relationship between physical exercise and testosterone,
Sure.
really, and it can just seem like the last straw when you're told, right, you can't drink, you can't have coffee, you can't basically go out, and now you can't cycle, and they just want to, they lose the will for anything, really. So, yeah, I would agree that everything really in moderation. I'm just looking at that question. Do you recommend DNA fragmentation with recurrent miscarriage? That is a brilliant question, because that actually came up in my clinic this morning.
Yeah. So, the recurrent miscarriage, of course, is a dreadful situation to be in, and I'm hugely sympathetic. I think that too often my lot, the tribe of doctors, try to make light of it with the best intentions by saying things like, well, you nearly made it. Now that is entirely to miss the point, particularly when there has been some difficulty in conception in the first place. Now, until relatively recently, it was thought that this was principally a female or a gynecological issue. And there are many tests for the female partner which might indicate a lack of receptivity of the uterus and other issues. But it's only relatively recently that men have been considered as possibly being a significant part of this problem. And it's really only been since DNA testing has been available, because often these miscarriages are happening in ladies whose partners have entirely normal semen analyses. And it wasn't until we started looking at these men with normal semen analyses in the same way as we look at men with unexplained infertility that we began to notice that DNA fragmentation is often raised in the male partners where there is recurrent miscarriage. Now, the work was done in this country in Birmingham by an excellent scientist who runs a seminology lab and has a great interest in DNA fragmentation. But it has been very slow to be adopted. There was a smaller series reported last year from Imperial and St Mary's, which showed that there was a coincidence of excess numbers of miscarriage, raised DNA fragmentation, and higher levels of reactive oxygen species, so the oxidative stress that we were talking about earlier that often accompanies DNA fragmentation. So I think men do have a significant part to play in this. Whether it is as much as 50%, I don't think anybody knows. But even if it's only 20% of the problem, then I am quite sure that it is worth investigating and trying to improve.
Thank you. And then another question actually related to the same subject, which you've probably sort of answered, and also comes up, is this is somebody who's had 2 donor egg donation cycles which have failed, and she has asked for DNA fragmentation, and her clinic say that it's not relevant or won't do it or whatever. Would you say that if you'd had a history of infertility and you were having egg donation, that it would be a good thing to do as a matter of course to have a DNA fragmentation test, or would it depend on a lot of other factors? And if you'd had failed egg donor cycles, do you think then that would be a reason to actually look more into the sperm?
So the last bit of the question I'm absolutely clear about. So a failed egg donor cycle, I think, means that you have to scrutinise that sperm, including, of course, DNA fragmentation, very carefully, and you may want to do many other tests before one risks another failure. The expense and the emotional toil on failing an egg donor cycle, when there's often
huge,
it often means that you've had failed cycles with your own eggs, and this really is devastating and terrible. Now, having said that, then that leads me on to the first bit of your question, which is, should you in any case, if you are thinking of donor eggs,
perhaps for unexplained or,
Well, I think certainly if things have not been quite as you might have expected in terms of the previous cycles, in other words, if despite a reasonable female age, the outcomes of previous cycles have not been as good as one might expect, if there had been fewer blastocysts, fewer pregnancies than you might expect, then these are all indications to look more carefully at the sperm. But my view, I don't think this is yet the view of the majority of fertility specialists, but my view is that if you've got as far as thinking about a donor cycle, for a relatively small expense, it is worth making as sure as you can be that everything is right on the male side.
Yes, I mean, I think it's ticking all the boxes, really, isn't it? Which kind of leads us on to the question about DNA frag, the controversy that rages around that. Another 3 questions or 2 questions have just popped up. You know, my clinic doesn't believe in it, my consultant doesn't believe in it. And then the other aspect that comes up about having a DNA frag test, well, you can have it, but there's nothing you can do about it. So would you just explain kind of what it is,
yes,
what its value is, and what you can maybe do about it?
So I think the point about the controversy needs some explanation. And I'm very sympathetic to my colleagues in gynecology run fertility units, because the information, both academic and anecdotal, about the different sorts of DNA fragmentation tests is not encouraging nor easy to understand. So there are 5 different tests used to try to quantify DNA damage in sperm. Now, to a certain extent, they all rely upon damaging the DNA and breaking up the sperm head before you then use some physical means of measuring how much it is disrupted. So as soon as you think about the process, the chemical process that the sperm are going through, it's not surprising that the different methodologies may, firstly, be measuring something slightly different, and secondly, might actually result in a different numeric result. So therefore, it is almost impossible to compare one type of DNA fragmentation test with another, and the result with one test may read 10 points higher or 10 points lower than another. So the doctors in the fertility clinics read the literature and they talk about it inter alia amongst themselves, and they come to the conclusion that these things don't seem to be reliable. But that's because they're not quite comparing like with like. And then the second issue is that there will be many people who've had DNA fragmentation tests which return a pretty bad, in inverted commas, result. And hey presto, here's this couple waiting for IVF, and she becomes pregnant naturally and they have a baby. And so the doctors in that fertility clinic, well, say to themselves, well, this is nonsense. Clearly, it doesn't mean anything. My answer to that is that every fragmentation test needs to be, the result needs to be looked at in the context of the particular couple. Because if there are lots of motile sperm, if the total motile sperm count is high, and if the female partner is young, then, in fact, those 2 things will override the DNA fragmentation issue. So that the DNA fragmentation doesn't look great, but there are so many motile sperm, and the female has such good quality eggs, that a natural conception and a live birth happens relatively easily. So every DNA fragmentation result has to be looked at in the context of the couple themselves and in the context of the semen analysis result. Now, the final thing that frustrates, I think, many people looking at fragmentation tests is that the results seem to be unnecessarily gloomy. That with some tests, they all seem to be abnormal. And it may well be that we, or the designers of the test, have set the threshold for normality a little bit too high. Because, of course, in order to say that a man's sperm, his fertility is absolutely normal, then he may have had to have proven his fertility on several occasions, and he'll probably be a young sperm donor. So actually not typical of many men, in society, going about their normal activities, who may not have a great DNA fragmentation, but have had 2 nice, normal children. So we've got to look at this in the round. But by the time you've got a problem, particularly if it is unexplained, then it is my belief that DNA fragmentation testing is useful.
Yes, so I think the take-home point from that is not to just have a random DNA frag test, which it is possible to do actually, and then you look at the results and you think, what do I do about this? It really needs to be in the context of what's been going on with you, but also seeing somebody like Johnathan, a urologist who has a special interest in male fertility, who knows about DNA fragmentation, who can then explain what to do. And the other thing that comes up a lot is, what do you do about it anyway? Yes, so clinics and consultants maybe believe there is something in the test, but then there's nothing you can do about it anyway. And that would again presumably lead on to varicocele, investigation of the testicles. I'll let you carry on, Johnathan.
Reactive oxygen species levels, looking for oxidative stress, and then looking for the reasons of oxidative stress. So there are 3 or 4 groups of conditions which are both identifiable and are often, not always, though, treatable. Because there are a group of men who have oxidative stress in their genital tract, so that is between the testicles and where the sperm joins the urethra in the penis, who have some inflammation in that urological, anatomical region of the body, and we cannot find reasons for it. But at least we know then why the sperm is deteriorating on its journey from the testicles. So, although our knowledge here is incomplete, I take the view that knowledge, to a certain extent, it puts a couple in a more powerful position, in a more discriminatory position, in a position that is less lost and seemingly less hopeless.
Thank you. I mean, from my point of view as well, I really believe that, I wouldn't I? But I believe that losing weight and switching to a Mediterranean-style diet, and it's all very multifactorial. There are lots of things that can help, and sometimes there aren't. And in fact, actually, somebody's just asked a question about DNA fragmentation and microteasy. The difference, which I think you just alluded to that, and is it important to do a DNA frag test if you are going for a microteasy? Okay. Extraction from the testicles. I'll let Johnathan explain what that is.
So there are a relatively few men who have high DNA fragmentation, who will usually have relatively normal semen analyses, relatively normal testicles, normal hormones, they have normal genetics. And these men who classically have unexplained infertility, therefore, will have a high DNA fragmentation. Then we look for all the normal causes of this. We look for the large varicoceles. We look for high levels of oxidative stress. We look for organisms, bacteria and germs that may be causing inflammation. We make sure the anatomy of the prostate gland is okay, the anatomy of the urethra, and all of this is fine. But still, the DNA fragmentation is raised, and the couple's story would suggest that it is the quality of the sperm that is frustrating their attempts to become pregnant, perhaps. There are very few blastocysts, and there haven't been any sustained pregnancies. Now, in these men, it may be, and I stress the word may be, that retrieving sperm directly from source will improve the outcome in terms of a pregnancy. It is usually the case that such sperm will have a better DNA quality. But of course that's not the whole answer. It's fine for the the clever doctors to say, oh, look what I've done, I've got you some sperm and we've measured it and it's better. But of course, that's no good unless it works, because the outcome of everything we do needs to be a baby. So I think the jury all over the world is still debating whether taking sperm directly from the testicle certainly results in more live births, because to prove that statement requires thousands of cycles using sperm retrieved from the testicle. And we haven't got thousands of cycles. If you ask me what I think that in a very significant percentage of men of the sort that I've just described, then testicular sperm retrieval and epididymal sperm retrieval may well represent a better chance of getting a live birth. That's what I believe. But there's a difference between what somebody like me thinks and believes and what has been proven evidentially, which is really difficult to do in fertility. What we are doing now is we're developing tests that might indicate whether that surgical sperm retrieval is likely in that individual to produce sperm of much better quality, so that we can choose, or better choose, the men who may benefit from this technique. Long answer, I'm sorry.
Long answer, no, I'm sure it's very gratefully received. I'm looking at the questions because the way we've got the phone means that I have to turn my head to look at the questions, and I'm so frightened of touching my phone and scrolling down, of cutting us all off, because I'm quite likely to do that, that some of you are going to think, bloody hell, she's not asking Mr. Ramsay our questions. So, got one actually, well, got a couple which I clocked. One was about having a normal semen analysis, usually having ulcerative colitis, so inflammatory bowel disease, having a flare-up between semen analysis and having a really bad result. Would that be connected?
Yes, I think.
And there's another one, sorry, Johnathan, just would significant digestive issues impact sperm quality, possibly through inflammatory bowel disease again, or celiac disease, but probably not IBS or anything like that, would you say?
Yes, no, I would. I think that inflammatory bowel disease, the inflammatory conditions, the many conditions that are nowadays treated particularly by biological agents, so we have inflammatory bowel disease, we've got psoriasis, psoriatic arthropathy, some of the other inflammatory musculoskeletal conditions. All of these, when they flare up, can be associated, I think, with a reduction in spermatogenesis and a reduction in sperm quality. Now, of course, this can be confused also, and we sometimes never know which of the two things it is, by the treatment of that flare-up, because if you are taking biological agents, these are very powerful drugs, and have some suppressant activity. So we never quite know whether it was the flare-up of the condition or the treatment of the flare-up that might have resulted in this deterioration. But once things are level and the flare-up has gone away and the dose of the drugs has levelled off, usually one will then see the true position.
Yeah, I mean, it's really unlucky if you get such a thing before you do a semen analysis. Would you say that these kind of major disruptive events, like, for example, getting flu, I understand, having a temperature can really impact sperm?
Yes, it can.
Going on a stag weekend, so I get your IVF done in the winter. June is just not a good month for anything like that. And moving on to, somebody has just asked about what your thoughts are on Pixie, IMSI. What do you think about people? Obviously, some bad press has been associated with these as being very expensive add-ons, not necessary for couples to do. Yeah. What do you think?
So the first thing to say in general about add-ons is that I have great sympathy with my colleagues, the gynecologists, who have really tried to solve the problem in the lab of a failure of fertilization or not getting sufficient numbers of blastocysts, things which broadly seem to be sperm related. And for many years, very genuine attempts have been made to treat the sperm in the lab, to find a way, a better way of sperm selection. Now, this is a tall order, and it is, for reasons, similar reasons that I alluded to before, it's extremely difficult to prove whether a new technique works, in inverted commas, because if we are trying to raise the live birth rate by 3 or 4 percentage points, then you need very many cycles of very similar people, both men and women, under similar circumstances, to try to prove that that is the case. So it's really, really difficult to prove. My own view is that all of these methods of sperm selection, which are designed to pick the sperm with the better DNA quality, do have some usefulness. It's not that they have no usefulness. They are managing to choose better sperm. But it doesn't make a huge difference to the outcome, and it's difficult to measure that difference. And so it gets a bad reputation. And if it is only available in private clinics, and if there is a charge for this, then of course, naturally, human nature dictates that somebody will start complaining and saying that it's only for profit. So I think there is a scientific basis to all of these things, but it doesn't raise the chances that much, and it's jolly difficult to prove.
Everything's difficult to prove, isn't it? Because you're never going to get anybody to go into a control group or a placebo group with fertility. If it's going to give you a baby, you're going to do it. You don't want to be in the control group. So, interesting question just come in now. What tests do you recommend we ask a urologist to test for? That's a really good question, because I'm saying, oh, just go and see a urologist. But then, what do? You find your urologist?
Well, you certainly,
what are you doing?
You absolutely get a physical examination, which is a jolly good start. You will probably get an ultrasound scan, because in certain cases, particularly when there's a very low sperm count, it's very important to do an ultrasound just to make sure that there isn't a tiny little testicular tumour or something like that. So the urologist all urologists are going to be particularly good at making sure there's nothing wrong with you. They're also going to be good at measuring hormones, because urologists are interested in what we call andrology, which is the whole of the man. So that is clearly a good thing to do. The urologist will be interested, again, if the sperm count is very low, in the genetics, and will be particularly interested in a history of urinary tract infections, of prostatitis, of problems with the urethra, urethral strictures. And so you'll get a good urological start to this. Now, when we get to the more sophisticated tests, like DNA fragmentation, then it's very difficult for most urologists, and indeed all urologists in the National Health Service, to be able to order this test, because it's expensive and because it hasn't yet become universally accepted and acceptable. So you won't go that far with the urologist, but I would, and once again I would say this, wouldn't I? It's not a bad start.
It must be a good start, because you've got to have somebody who understands about everything. And presumably, say you've got a low sperm count, then, in fact, that was a question actually, but now come on to reasons. Can you improve sperm count with drugs, with diet and lifestyle? I would say, again, yes, if you lose weight, very important for improving sperm count. But what would you do with a man with a low sperm count?
I mean, there are lots of things that we've got to talk about in consultation, and some of these things may not be obvious to the men. They're the hair restoring drugs, particularly finasteride, Propecia, use of proteins, often laced with a bit of steroid, or indeed straightforward steroids.
Steroids, big thing at the moment.
Very big thing.
Those of you who watch The Archers, listen to The Archers, it's probably not very many of you. anyway, there's a steroid story in the Archers. He's working out in the gym, and people don't realise what a devastating effect taking anabolic steroids has on male fertility.
Yeah, and some of it, although mostly reversible, sometimes after a lot of steroid abuse, it isn't. I'm very impressed it's gone into the Archers.
I know, everything gets
Right.
into the Archers. We've
Public
had them
information.
lot.
Good
Yes.
old BBC public information.
But I think it's a big thing. We've had a question which is from somebody saying, how long is a sperm affected post-stag, for instance? So maybe this person has either been on a stag. I guess it depends on the sort of length of
Sure.
were you tied up, stripped naked and tied to a lamppost, you might take a bit longer to recover.
So there's the effect on the poor old sperm that have already been produced, and probably it won't be that much on those, as it were, that are waiting post-production to come out. The effect of mild poisonings often doesn't develop for several weeks thereafter. And so Melanie was talking about fever. So the effect of a fever may not be evident for a couple of months, may still be lingering around 3 months after that time. And the effect of significant life events might not just be a stag night. I remember one man who I was talking to who was terribly fit, tremendously fit, and he used to run all over the place, and he'd just done a run overnight from one far away place to another place very far away, and this had been extremely exhausting. He admitted that it was rather tiring, and his partner, who was sitting there, said, well, I think you're a bit understating it, she said, rather tiring. She turned to me and said, he collapsed and had to be taken to hospital.
Oh my God! And he was doing a semen sample.
And the semen sample,
oh my God,
2 months later, was azoospermic, no sperm.
Wow. So
and
the stress.
Given another 2 months, then he was back to normal.
Yeah.
So these things can be, the body as a biological system does shut off spermatogenesis when there are stressful, particularly febrile illnesses and disruptions.
Yeah, so lots of heat. Now, I think I've probably taken rather a lot of your time, Mr. Ramsay, but I think I've had so many questions in that we may actually have to do this again, because my inability to cope with Instagram, although I am learning very hard, very fast, has meant that I'm just too frightened to scroll up and down on the screen, because I'm sure I'm going to cut us all off. But there were lots of questions there, but I think we've covered quite a few. Lots of people have asked, how do you improve count? How do you improve morphology? How do you improve motility? And I think probably every individual probably needs to be assessed on their own merits. But the main take-home message of this is that the man is really, really important, that he cannot be dismissed as not being important in a couple's fertility, infertility quest for a baby. And I think if you just fight your corner, and we get a few more urologists like Johnathan coming up in the new generation, which hopefully, it's such an interesting subject, hopefully that will happen.
I mean, there are.
There are. Yeah. So you can't retire now for, many years. You have to stay in the business. So, so thanks very much for all your questions and for everybody that's joined. And we'll definitely do it again and get Johnathan in again and answer a few more of your questions. Thanks a lot.
Good. Thank you all.